Pediatric osteomyelitis, a comprehensive overview. Definition. Osteomyelitis is an infection of the bone, typically caused by bacteria, though fungi and viruses can also be culprits. In children, it is commonly an acute condition that affects long bones due to their rich blood supply and active growth plates. Types of osteomyelitis. 1. Acute osteomyelitis. Develops suddenly, usually within days to weeks. Characterized by pain, fever, swelling, and redness. Most common in children due to their vascular bone structure. 2. Subacute osteomyelitis. Develops more gradually over weeks to months. Less severe symptoms compared to acute osteomyelitis. Example, Brody's abscess, localized infection inside the bone. 3. Chronic osteomyelitis. Persistent infection lasting months or years. May result from inadequate treatment of acute osteomyelitis. Characterized by bone necrosis, draining sinuses, and sequestrum formation. 4. Hematogenous osteomyelitis. Infection spreads through the bloodstream, most common in children. Typically affects metaphysis of long bones. 5. Contiguous osteomyelitis. Direct infection from nearby soft tissue infections, open fractures, or surgery. 6. Osteomyelitis in sickle cell disease. Commonly caused by Salmonella species. Patients may have multiple bone sites involved. Most common sites in children. Long bones. Femur, most common. Tibia. Humerus. Other locations. Vertebrae, in older children and adolescents. Pelvis, less common. The metaphysis of long bones is most frequently affected because of the sluggish blood flow and lack of phagocytic activity in these areas. Modes of diagnosis. Clinical features. Fever, malaise. Localized bone pain, tenderness. Swelling, redness, and warmth over the affected bone. Limping or refusal to bear weight, if lower limb is involved. Laboratory tests. 1. Blood tests. CBC, elevated WBC count, leukocytosis. ESR and CRP, markers of inflammation, usually elevated. Blood cultures, identify causative organism, positive in 50% of cases. 2. Microbiology. Bone aspirate or biopsy, gold standard for diagnosis. Gram stain and culture to identify bacteria. Imaging studies. 1. X-ray, plain radiograph. Often normal in early stages. Late findings, periosteal reaction, bone destruction, and sequestrum formation. 2. Ultrasound. Useful for detecting subperiosteal abscesses. Can guide needle aspiration. 3. MRI, magnetic resonance imaging, best imaging modality. High sensitivity for detecting early bone and soft tissue involvement. Shows marrow edema and abscess formation. 4. CT scan. Helps visualize bone destruction. Useful for detecting sequestrum and involucrum in chronic cases. 5. Radionuclide bone scan, technetium 99M scan. Detects early bone changes when MRI is unavailable. Shows increased uptake in infected bone. Treatment of pediatric osteomyelitis. 1. Empirical antibiotic therapy, followed by oral.